It is completely appropriate that we finish by looking into the future. And that is the focus of our panel today. We're going to be looking into the future of the healthcare in Utah and what that might look like in a year or two or more. I love this kind of thing. I'm an economist by training, so what we do for a living is to forecast the future. We take great pride in our success in forecasting the future. We've successfully forecast 7 of the last 4 recessions. So hopefully maybe we'll have at least that good of a record in looking to the future today. But what we're going to do, we have today with us Greg Bell, President and CEO of the Utah Hospital Association, Marti Lolli, who is the CEO of SelectHealth, and Michael Good, Dr. Good, with the University Health System. Did I get that right?
Correct.
Okay, good. So these are 3 people who, as part of what they do for a living, is look into the future and to anticipate, what the issues and problems will be and to deal with those. So let's just give each of you a chance to look into the future. Tell us what you see as the problems, the issues, the challenges, what we need to do, what's the future going to look like. Greg, let's start with you.
Well, thank you, and thank you all for coming and for staying. What's hard about the future, right? I mean, 3 years ago, a pandemic. 3 months ago, Ukraine. The future just is just so imponderable. And it seems the imponderability seemed to be accelerating. But still, there are some trends that we've lived with and probably will continue, good and bad. In healthcare, we're trying to deal with the expense, right? Just the upward cost curve of healthcare. We have wonderful healthcare, it's just too expensive. Now, it's not as expensive as newspapers always try to make it when we compare with Europe on like-to-like social expenditures versus private expenditures. We're not horrible, but it's certainly not affordable in anybody's definition. But there are several forces at work, good and bad, right? Technology. Technology on the good side, we now have almost completely functional robotic limbs and prosthetics. We have new progress in jumping the gap on spinal cord injuries. We have implantable defib machines, restoring life and predictability of life to people with heart events. We have artificially intelligent-driven pancreases in development. We have surgical interventions and imaging interventions that are just space age. So we all love technology. Technology is awesome, but it's bringing us this crop of products that advances medical care, extends life, but they're expensive. They're very expensive often, and sometimes you're developing them for a very low audience. So, we have to make hard decisions about some of these technological advances. Same thing exactly with pharmaceuticals. I mean, who hasn't been dazzled by the development of the mRNA vaccines for COVID? They've just been astonishing. Now, the technology had been developed fortuitously over the prior decade, but the immediate almost response of warp speed, and then the even faster development of therapeutics, and monoclonal antibodies to COVID, and now the molnupiravir and other pharmaceuticals. Again, wonder drugs, but very, very expensive. AIDS is now fully treatable. Many cancers are now not even listed as cancers, but as syndromes because they're fully treatable and curable. We have a high rate of insurance. COVID has brought so many people into Medicaid and other public programs. The low unemployment rate and the higher competitive search for workers has made the market all of a sudden a seeker's market, so that employers have raised wages, they've increased benefits, they've extended more insurance to workers. Whether that lasts through a recession or a downturn is yet to be seen, but all of a sudden we just are on the upswing from where we've been historically. We have a more expensive and a rarer, harder to find workforce in our healthcare systems. Everyone's facing the same problem, from social workers to dietary workers to housekeepers to nurses. And you don't replace those people with robots. We have an aging population in the nation and even in Utah. Our births per household are declining. And so while we've always led the nation, we'll still be the youngest state, we still have an aging, which means a more medically complex population. Population health as a nation, notwithstanding our increased medical care and even increased access, we're seeing worse health. And certainly the pandemic depressed our averages, but we have people who, though we want to talk about expensive hospitalizations and greedy providers and rapacious insurers, we're treating sick people. We're treating people who are blowing out their natural limbs because of weight issues. We're seeing an increase in, almost a double-digit increase in diabetes, very expensive, unforgiving drug across the spectrum. And so Americans are literally eating themselves to death. Our caloric intake has increased by 20 to 25% since the late 1980s. We see children absorbed in screens. 99% of all bicycle trips are made by people over 18. Compare that with me when I was growing up, riding my little bike everywhere. Our suburban lifestyle, our car-dependent lifestyle, now working at home remotely, we have big challenges in just our population health. We're sedentary and we're eating a lot more, and we're eating less healthy foods. We're eating processed foods, we're avoiding the fruit and the chickpeas, and we're eating the quick brownie out there, and that's just a way of life, right? So these are some of the pluses and minuses, and I have a few more, but I'll stop there, Vern.
Okay, well, maybe we can get back to that. Marty, the future from the mountaintop on which you said.
Great, Marti Lolli. I'm one of the did you say rapacious insurers?
Yeah.
I'm on the rapacious insurer side, SelectHealth, so largest health insurance carrier here in Utah. I'm new though. I'm new to Utah within the last 8 months, and if it's okay, I'll kind of highlight 4 things and reflect on, as a newcomer into this community, how I see we might be uniquely positioned to solve those things. So the one is, affordability by and large dominates my day. It dominates conversations. Many of you all of you hopefully are purchasers of healthcare. You're either paying for that out of your own money, you're paying for that on behalf of your employees, and more we hear this cost trend is unsustainable. Consumers are not getting the raises in wages to make up for what we're having to pay. And employers aren't able to go charge more for their products. So, I think it was last year we actually, surpassed the $25,000 mark in terms of what a family has to pay for insurance per year. And that's not counting things like deductibles, the number one selling product in the individual market, so those under Obamacare, is a $14,000 deductible. And so the reality of costs is just always something we're thinking about. When I look at a federal level, Medicare Trust Fund, for those of us that are counting on that being there, as it turns out will be bankrupt in 2024. So we have these real will have spent all the money that it has, that we're all paying today out of our paychecks for that insurance that we expect to have. So Costs are just a real problem, and there are huge opportunities, but there's no silver bullet. And so, whether it's the federal government trying to understand how to fund Medicaid, the state government trying to understand Medicaid, the federal on Medicare, and then we have exchanges that are subsidized and employers. Everyone's just really saying we're coming to a precipice here, and we have to solve this problem. There are lots of good actors and bad actors in that equation, and won't spend as much time on that, but really talk about, I think, the second thing. And it was fun to watch Governor Leavitt hit on this issue of really aligning everyone in the same direction when it comes to cost and clinical outcomes. And so some folks call that value-based care, risk arrangements, total cost of care, where those who are engaged in the healthcare dynamic are all thinking and motivated similarly to do the right thing. And so the fee-for-service model that we've had in healthcare is a little like crack cocaine, right? It's addictive. It's if I do more things, I get paid more. And that's how pharmacies, motivated hospital systems and providers in the past. And so how do we all align around the right care at the right place at the right time? And sometimes that actually means more care, right? But it could be a conversation around outcomes and not just about doing more things. And I think that's where we're really well positioned in Utah to drive that conversation in a productive way. We have the governor who's organized thoughtfully around that. We have healthcare systems, right, who, Mike and I think about that all day. How do we really make sure that how we're delivering care is aligned financially and clinically with the best outcomes? And that there's huge opportunity there, and Utah has been really a beacon state in helping the rest of the community think about transforming. And the one thing I'll say, having worked in other markets as well, is this idea that passing money from the insurance side to the delivery side is going to transform how care is delivered at the front line. That is a myth. Been there, done that. And what we have to understand is there's real change that has to happen in the way the providers interact with the patients, and even which patients they proactively get to come in to receive care, right? So gone are the days of opening up your panel to whoever wants to come in, and we should be issuing the days of getting the most complex folks into the office, giving them more time in the office, and I think that value-based care will really move us forward. And I think we can be a beacon of that. The third thing I would say is, we have to get out of believing that we can transform healthcare in the four walls of our hospitals or our provider practices. And it's tracking a little bit with what was said earlier. More of what impacts someone's health trajectory has nothing to do with the healthcare systems, right? And so how do we think about things like, the social determinants, getting right care to the folks who don't have it? And I think actually looking at studies, we have a real crisis in the Mountain West states around mental health. We compose 8 of the bottom 10 in terms of services and suicide rates. And so I think just looking and attacking and approaching that in a unique way, we have real opportunity. It's a great, there's more sun here. I just came from the land of Michigan, 90 more days of sun out here. So we should naturally be, lighter hearted, it would seem. But we have real issues. And so being thoughtful, being activated on that is important. And the final thing that I would add is I believe healthcare has to transform to be more consumer focused. And consumerism is real, and we've been lagging, and we have to move from population health, I believe, to personalized health. So treating clusters of folks with diabetes as if they're all the same couldn't be more opposite of what you need to do to move the needle on health outcomes. And there's a lot of principles, behavioral economics around nudging people toward healthier outcomes, and each person needs something different. And so how we're kind of thinking about it is, gone are the days of one program to support the class of those that have diabetes, and it's more around having 8 to 10 and understanding what's going to work better, and how do I engage you is different than how I would engage you. And so moving from population health to a consumer-focused approach where it's personalized health, recognizing each person's unique and nudging them in a timely way through digital and analytics to really drive outcomes, I think is another area. We have so much data in healthcare, and it's not used to really optimize that patient interaction. And so those would be my 4 thoughts about the future, and I think how we can really, really stand up in Utah and make some pretty incredible changes.
Oh, super. Dr. Good.
Always challenging to be at the end of a panel with great colleagues. So I'll start off by just saying that in the future, there's at least 2 more Pac-12 championships for the University of Utah football team. Oh, sorry, wrong conference. I similarly will share 4 ideas about the future in healthcare. 3 of them really excite me, and 1 worries me. And I do think, Vern, as you pointed out, we start in the other panelists, we start in a very strong position here in Utah. We've traditionally had a younger, healthier population, although, Greg, as you pointed out, those demographics are changing and rather rapidly. And that means maintaining that value, the quality-cost relationship, is going to get harder and harder for us. But we start in a strong position, and that's in a good position to be, because I do believe we can lead the nation as we work together. So my 3 phrases, if you will, are innovation, collaborative partnerships, and population health. So Greg reviewed a really nice list of innovations. Quite honestly, the joy of my job as a leader at the University of Utah Health is learning about all of the work and discoveries that's going on from what we call basic science, wet bench, inside of cells trying to figure things out, to translational, and clinical, and population health, from devices. We have a therapeutics accelerator. We have an orthopedic innovation center. I know my environment best, but I also know the innovative environment permeates our community. At University of Utah Health, we're working a lot with Silicon Slopes and getting to know their companies, many of them working in the healthcare space, and many not working in the healthcare space who are looking to make sure their employees have great healthcare. I think digital health, how many in the audience in the last year have had a virtual visit with a healthcare provider? Okay, now keep your hands up. How many had a virtual visit with their provider before the pandemic? Yeah, okay, so I make my case. Many of us think somewhere between 5 and 10 years of advancement in digital health happened by necessity during the pandemic. And our health systems, all of us are working now to figure out, so much of healthcare does rely on the relationship and the being physically present with your provider. Physical examination is an important part of medicine. But we have learned that we can get a lot of things done, particularly in combination with in-person and virtual visits. And I think our technology that we utilize for those are really evolving. I'm watching the so-called artificial intelligence or advanced analytics. We've got a group, one of the more expensive diseases to have is renal failure that progresses to the state where you're going to need dialysis to stay alive. And we've got teams using analytics to predict who's going to develop renal failure, particularly those that are a year or 2 out. So imagine if we could target very specific interventions and prevent or even delay for 5 or 10 years somebody moving from a state where they don't need dialysis to when they do. And there are just many, many examples. Again, cost was mentioned. Perhaps one of the most frequent and expensive decisions in healthcare is to admit or not admit. And we've got a number of initiatives, again, throughout our health systems. Ours, we have both Heal at Home and Huntsman at Home for our cancer patients. And we're implementing innovative care pathways where patients who would traditionally or historically been admitted to the hospital, we're learning how to take care of them at home. It's in its infancy, but each time we're able to provide care for someone at home rather than in the hospital, we've really saved a lot of funds from the healthcare system. So innovation, we could probably talk an hour of that, but that's clearly
It's another conference
part
by
of,
itself,
right, part of the future. And again, I think Utah will lead. Partnerships. Greg, I really got to give the Hospital Association. I was relatively new when the pandemic was hitting, and I thought the Hospital Association became a convener of our health systems and really got us working together. I mean, at one point in the pandemic, we were, the term of art is load balancing. You know, one hospital's overwhelmed with COVID patients. And through our chief medical officers coming together in a partnership way that I've never seen before, we helped arrange care so we could get as many patients taken care of and utilized each other's facilities. So I think collaborative partnerships are strong. I know Governor Cox's One Utah initiative has been a topic of this conference. And once again, we've got, in I think other states and in other periods of time, individuals who didn't come together. I noticed they used the word silo in the program about our panel here, and I'll challenge that. I think the partnerships in this state are evolving rapidly and they're strong, and I think that will be part of our future. And then I do think population health is a part. As a physician, as an anesthesiologist, I was trained to take care of the patient that's in front of me right now. And that will and always remain critically important. But increasingly we know, and it's been touched on by the previous speakers, that there is value in looking at a group of individuals and say, how can we better shape the care for those individuals, those specific individuals? You know, during the pandemic, if you were a physician in the emergency room and you stood at the door of the emergency room and you would see patients coming in respiratory distress, and you'd say, you know, this patient may have COVID, you'd test them and you'd take care of them. And then the next one and the next one. And if you just keep that focus on that care team, that patient providing great care, you get one dimension of our healthcare system. But when you start saying, okay, let me look at the population of patients who have entered my hospital with COVID. If you do that here in Salt Lake, for example, you'll notice that 20% of our population is made up by Hispanic and Latinx individuals, and yet they're accounting for 40% of our COVID cases. And you then have to begin to go deeper and understand how are people, what are their living experiences? What are their education experiences? What are their working experiences? And you have to go into the so-called social determinants of health, where 60 to 80% of health is actually determined. And so I'm proud of, we're working with Intermountain Healthcare, actually at the medical school level. We've developed a population health approach to the medical school curriculum at the Spencer Fox Eccles School of Medicine. I believe one of the first in the state, and we're still putting all the pieces of that together day by day. We'll admit our second group of medical students into that curriculum here in the coming months. So innovation, collaborative partnerships, and population health get me excited about the future. The part where I'm now losing sleep is our workforce. Healthcare is a human endeavor. The vast majority of healthcare is delivered by one human being to another, by groups of human beings to other human beings. And like many aspects, whether it's our thriving economy and the low unemployment, or just some of the pressures and dynamics of the healthcare space in specific. But if anybody's looking for a job in healthcare, I've got my card. We're open for business at University of Utah Health. I'm sure it's true for all our healthcare partners. But we're going to have to think about who we bring into the healthcare team, how we divide up the work. Healthcare is delivered in teams. We're going to have to, putting the two together, we're going to have to innovate in the workforce space because it's going to be hard to keep up with all the care demands of our growing population with a stable, in some cases, shrinking healthcare workforce. So that's the one that worries me.
Great look into the future. So many places we could go to carry on, but I just want to pick up a little bit on where you were talking about as a physician. You're making people healthier one patient at a time. And what I heard you all say in one way or another was that we're moving toward population health, where you're making people healthier 1,000 people at a time, or 100,000 people at a time, or even 1 million people at a time. It's the population health focus, bringing in those non-medical things that affect health. And kind of between the lines, what I hear you saying is, we're focusing not just on the healthcare this person needs, but making the population healthier. Could you all say a little bit more about bringing in social determinants of health and how population health is going to change what you do in the future? I don't know. Marty, can I start with you?
Yeah, I think there are a couple things. I think looking at populations to understand evidence-based medicine and what works is absolutely essential. But then you start layering on advancements in genetics and mapping of genes, and it really opens up a whole new space of adding greater specificity at the person level around propensity and treatment, right? And so I think that's super exciting as we start looking into the future. And this is very early, right? I mean, this is early science. There are some studies, and Intermountain has an initiative to try to gather, mapping on 400,000 people, largest study, and really start drawing conclusions. So how can we understand? The interesting thing I'll share, we just learned, 50% of the people said if there was something identified, they did not want to know. If there was something in the gene that had said you're likely to have, right, they did not want to know. And I think that's really interesting, right? But when I was just talking to some folks today from our population health function, and I think there's a part of healthcare that's been super focused, and I can say this as leading our pop health efforts, on the academics of it, that we've forgotten that these are people. And years ago, I was in a room and we were trying to figure out how to help those with diabetes become adherent. And the cost of diabetes at the time was about $11,000 a year. If you're not adherent, it doubles. And so, there's real opportunity here. It's 20% of the population almost that's either diabetic or pre-diabetic. So when we were talking about what we thought people needed, we sat in a room, and I was the naive, sort of like, have we asked people, like, what gets in the way? And we did this great research, and you would be shocked. I mean, some people said, I don't take my insulin because I can't afford it. I'm reusing needles. Half of the research group that we had was reusing needles. They said, it's something I live with every day. You don't understand that. I interact with my doctor 1% of my life, right? And 99% I'm dealing with this on my own. A lot of people had made up terms for what they had, like it wasn't even real clinical terminology. And so when I say personalized, I mean really getting down to understanding what is the uniqueness of that individual situation. And you know, we've seen personalization every day. We see it in how we interact with Netflix. We see it in what Starbucks does to convince us all to buy more coffee or a scone or whatever it is. And so there's so much opportunity for healthcare to use population health, what we know works, but also personalized health to actually nudge people along their healthcare journey to better outcomes. And shame on us for not using that sooner, because it works. That's why we all buy those recommendations on Amazon. That's why we check out that new thing on Netflix, and our work is so much more knowable. So the machine learning algorithms that you put behind that and that we're building really help you deliver using the data you have on improving healthcare outcomes. But I'm so excited about the future of healthcare. But to the point about, you know, what am I nervous about? Why don't we want to know? 50% of us don't want to know what it is that we should be concerned with so we can start treating it today. And that's also really fascinating to me, the human psychology of that. So that's what I would say on that point.
Greg, what would you add?
Well, there are at least two models. I don't know which one's going to win, right? One is the Jiffy Lube model, where I don't have a relationship, right? I notice my oil needs changing, and I wait 1,000 miles, and then one day I have a half hour, so I go to Jiffy Lube, and I get it changed. Now, that's kind of the individualized medicine. I get on the internet, and I just, oh, man, I have the symptoms of Ehlers-Danlos syndrome. I'm going to go to a specialty clinic in Alabama to a chiropractor who specializes ostensibly in this, you know, and he's going to give me a mixture of wood ticks to drink. I don't, you know. Or, you know, Beverly Hills plastic surgery. So it's just this whole boutique. You can have anything as long as you can pay for it. I met an Amish couple on the train going from Michigan to Juarez, Mexico, to do some concierge heart surgery because it was so much less expensive there, you know. So on the one hand, we've got the Jiffy Lube model. On the other hand, we've got, I don't want to be unfair, but kind of the Mike Levitt value-based, system-intensive, you know, sticky, you're part of us, we're part of you. Physicians, hospitals have risk because you're within our population. We're going to high grade and look at the high priority people, that sort of thing. I think we're going to have both, and I don't know that one's going to win. The other thing that we need to do, though, and almost every panel I've been to has talked, every panel I've heard today, and that is more integration, less of the wrong door, right? Mm-hmm. I mean, I think everybody agrees there are lots of wrong doors. Mm-hmm. You know, our system is just not integrated, especially relative to mental health, substance use disorder. And, you know, we are beginning a coalition of state and Intermountain University, HCA, and others are beginning an assessment of the mental health system state-wide, top to bottom, border to border, every system, every state agency who touches these two things, mental health and substance use disorder. We're going to baseline study it, and then we're going to help with stakeholders build a system, when I say integrated, a system that talks to each other. So whether you show up at the emergency room, the mental health clinic, your PCP, employee assistance through your employer, that somehow you get tied into services, and if it goes the mental health way, the dual diagnosis way, or the substance use way, at least you're getting tied in to resources. And that's just an absolute must-do. That's what I've staked my career on in the next few years, is that's number one for me.
So, Michael, what would you add?
Yeah, I think one of the things that makes population health challenging is it means many different things to different people. And sometimes when we say population, we mean, well, the whole state of Utah, or even, you know, the whole nation. I think to be successful, you need to be very clear what the population is that you're working to improve the health on. And I do think I'm with you at 10,000 and maybe 100, but I don't, at least I think you have to be able to say, this is the population. You then need to look and say, what are the most challenging, specific health challenges of that population that we can impact, and then figure out care pathways that address them. I'll give you 2 examples. At University of Utah Health, Dr. Peter Weir, Dr. Banks, and others have developed the intensive outpatient clinic for our highest cost Medicaid patients. And I'll be succinct because we did a 10-minute documentary film on this as part of the Sundance Festival. And if you just Google "Meet Me Where I Am," University of Utah, you'll see this documentary. But so really health-challenged, high-cost Medicaid patients, and we took average costs of $50,000 to $70,000 per beneficiary down to $25,000 to $30,000 and sustained them there for 3 years while the control group, if you will, continued to have those $50,000, $60,000, $70,000 costs per year. And it does. We not only provided great health care and some of the health problems that we've discussed today, but making sure people had their electricity on and some place to sleep at night and things like that. We also have Arup Laboratories as part of the university, and they have taken on the health of their employees in a very intentional and focused way. Now, that's a very different population. It's the 4,000 employees and their families, the employees that work at Arup Laboratories and their families. And they identified a different set of issues from that population that needed to be focused on. So the strategies that worked with that Medicaid population, there's a different set of strategies you need in this case for an employed population. They utilized the workday with on-site clinics and assignments that included seeing the physician or the care team for some very specific ways. So one of my messages is population health is not something you do for everybody the same way. So I guess I'm coming around to agree with you, Marty, is that, but I do think you can look at thousands and tens of thousands, and then from there, identify the issues that are really driving bad outcomes or less than optimal outcomes and high cost, low value care, and go at it in that very focused way.
Yeah, so it actually made me think, maybe it isn't a million people at a time. That's the public health officer.
Now you're playing your own court.
Right. But I was waiting for one of you to talk about the financing system and the payment system. What would you say about what is reimbursed and how it's reimbursed and how that can get us to where we need to get to?
Yeah, so I think that's why we saw the movement to telehealth, right? Virtual, and I hope it doesn't slow down, but so as CMS goes, so goes healthcare, right? Fortunate or unfortunate. And what we saw CMS do is mandate and pay for virtual care at the same level as physical care. And I think that, when healthcare models, I had the opportunity, it was fantastic. Michael Porter, if you haven't read his book, for those of you that are really interested, did a great book on sort of healthcare. He didn't use the word reform, but it was, he tackles the toughest problems in the world, like world hunger, and, healthcare solutions was a part of that. And, there is alignment that is essential. And I'll give you an example of what, I've seen in this market and other markets are similar, and I really appreciated some of the clinic examples that were provided. So when physicians are reimbursed on their current model of RBUs, it's a volume-based model. So you could actually be changing the overall reimbursement rate to the system, to the larger organization. But if it doesn't translate down to the doctors, it's still a volume-based business, right? And so one of the things that was really cool about, you see this model in Nevada, and then Intermountain adopted it here. They called it Reimagine Primary Care. And the only people that are allowed to come to their clinics are those in value-based arrangements with payers. Because only when you're in a value-based arrangement as a provider can you afford to do the right things like care management or give that one difficult patient more time, right? And so the current system doesn't reimburse for those things. And so by entering into risk or value-based contract, then the doctors and the hospital systems can deliver care differently. And so I'll give you an example because I visited one. So if a patient, they have an appointment with a patient, first of all, they huddle every day and they decide if they have the right patients coming in. And who do they need to get in next week based on, someone was admitted or, they need to close a gap in care or, you name it. They have a list of people who pop up and they're not waiting for the person to call. They call that person and say, you need to come in. So they're managing who's on the panel. The doctors have more time, but in other cases, the patient says, I'm frail, I have mobility issues, and doctor's like, no sweat. We'll do a phone call, we'll do a virtual visit. So in today's world, that doesn't happen as much, or I'll text you. How about the reimbursement doesn't align to enable them to practice medicine that way. And then the great story is it works great. The patients are most satisfied in those clinics, and the physicians are most satisfied because they're not rushed with a production. They're paid based on their panel. So I think, kind of thinking about how does this flow through, the money does, the incentives have to align from tip to tail, I think, for it to work. In a lot of cases, it's broken and it doesn't.
Can I ask,
Yeah.
are we okay with our system of deductibles and copays? I mean, are we really aligning consumer incentives?
I think a system where you can, that's a great question. I think I've seen a lot of success on high deductible health plans where the consumer is engaged because there are options. So if I walked in, if you gave me a choice and you said, let's go to dinner, Wendy's or Ruth's Chris, and you pay the same, you're going to pick Ruth's Chris, right? So in a model where insurance is designed, right? I mean, you're the economist, it's moral hazard, right? Is the economic phrase.
That's good.
You have common property that as a consumer, I'm not responsible for making good decisions. It assumes it's a moral hazard because we all are to be good stewards, right? And so if to equate it to auto insurance, if auto insurance covered not just your accidents, but your new paint job and new tires and oil fill, you might do those things a little more, right? So it is a challenge to figure out how do you engage the consumers of healthcare, who are almost never the payers of healthcare, to be good stewards of that. Because insurance is, we all put money in the pot. And actually, we're all paying, right, for the top 20%, right? So remember, 80% of healthcare dollars are spent by 20%. And in fact, 50% of healthcare dollars are spent by 5% of the people. So those are people who need us. It's a system that says if we all pay in and we're all good stewards of that money, it can help carry in our sickest times, in our most vulnerable times as patients when we need that. We can't afford that $1 million surgery or that $1 million prescription drug. There are those out there. That's kind of what insurance is. So it's a moral hazard. So how do you engage consumers? I think really hard. Is there a model that says we can deliver on healthcare without engaging consumers financially? I'm not sure. I'd love to see it.
The challenging problem. The part I'm encouraged by, we've talked a lot about the consumer, but it's actually the employers, particularly here in Utah, the employers that are paying for a large part of the healthcare system, putting in the as you said, the money into the system. And for a long time, that was kind of a hands-off relationship managed by intermediaries. And certainly in our conversations, we're talking with employers and saying, how do we partner? I had a chief HR officer of a large corporation saying, I'm paying for this expensive benefit and I'm not sure my employees value it. Mm-hmm. And so we have to engage together, try to understand what the employer is trying to accomplish, what the employees are trying to do with their health. And I think that's an emerging dynamic that will continue to grow, is the engagement of the employer in these conversations to figure out how to make the financing work.
Yeah, so you mentioned employers, and we've talked a little bit about the cost and so on. The cost of healthcare continues to go up. And the prices, the cost within healthcare is going up faster than wages or other things. And so a greater share of household budgets, employer budgets going to healthcare. It was mentioned before, enormous pressure. Are the things we're talking about now, about the future, the population health, the social determinants, is that going to be enough to relieve the pressure in the future, or is that pressure going to build?
I don't know, because the reason I cited so many technologies, they're life extending, they're wonderful. When we're sitting there with our daughter or our wife and they say, well, there's this therapy that will extend her life 5 years, you know, well, footnote, it's going to cost $2.3 million. You know, well, we're not going to make that cost-benefit decision as an involved party. So I don't know. These technologies and pharmaceuticals are wondrous and incredibly expensive. So that's just a social issue we have to face. It's the death panel issue, right? It's the 1990s. We already did it, and then we tried death panels. So there are, I mean, pejoratively, that was noised about. You know, so there are some offsets. But to me, the best case we're going to have, I remember in the mid-2000s, Utah was a leader in homelessness services and low count of homeless. To me, that's when we had the problem as much as possible in hand. And the homeless people who were identified had case managers. Whether they were on the street or whether they were in transitional or remedial housing, they had a case manager who was working on their SSI, their veteran benefits, their health care, their, you know, the income, filing taxes, EITC, the whole package. They had a case manager who knew them and was helping them navigate complex systems, because these are difficult systems, right? I think when we have something like that, a PCP or case manager, where it's expensive on the front end to help critically ill or chronic patients, guide them through the system. Then when we have a longer-term relationship with patients, more than an insurance year, so insurance companies have incentives with a longer-term relationship to get upstream, to know the heart attack guy 5 years ago, to make sure, help him exercise, help him understand his risk, help him take beta blockers, et cetera, et cetera. I think a combination of those things with redesigned insurance packages and value-based incentives on the other side, that's the best shot we have.
So let me finish up with this question. In the future, are we going to be healthier? Are we going to live longer? And is it going to cost less? What do you think?
Yeah. I, again, with the aside from the pandemic, which had a surprisingly, or substantial, I guess is a better word, lowering of life expectancy. But certainly prior to, and I do expect that extension of life expectancy to continue. So I do think we're going to live longer. I think the challenge, that's what we've here been talking about, the lowest cost health care is health. When you don't need health care or you need,
Right.
And so I think that is the challenge. We are going to be living longer. Many of the high cost diseases that challenge our health do occur in the latter decades. So I think that's the whole reason we're having this conversation is how do we use all the things I talked about, the innovation, the partnerships, the population health approaches to stabilize that cost curve. What was the live longer, the cost, what was the first one?
Live longer, be healthier.
Be healthier.
Yeah.
I'll be an optimist. I'll say yes.
Okay.
That's great. I think, I'll end with what I said. There's no silver bullet. I think if we're looking for that, we're going to be wasting our time. And the discipline it takes around the three cost issues that I always have my eye on. I think there's a lot of bad behavior in pharma. And I get excited about bold moves to try to address that. The increases that we experience are tremendous. In my role, in our role, we're going to be diligent about managing costs. We're the lowest admin insurer in the country. We're a nonprofit, so we are super efficient. And I think then, remember, 75 to 80% of the costs are related to chronic disease, and the majority of that's preventable. And so I think that getting further upstream is absolutely essential, and that's something that we'll continue to be focused on. Partnering with our customers on health insurance that they can afford, right? I mean that's the dilemma. We'd all love first dollar coverage and everything, but frankly, we can't afford that. Insurance is a additive. It's adding up the costs of the services that we all want and need, and so it's really attacking those services and driving better health.
Okay, last word. It's all been said. Go ahead.
I'm excited to see when you look at our healthcare in Utah, there's so much to be grateful for. Really, our healthcare is just non-pariah. I think we're going to have challenges with costs though because of the innovation and the technology in pharmaceuticals. We've probably got to have some strong federal action on pharmaceuticals, and we're going to have to make some social decisions about affording some technologies that are quite advanced. But I just think we need to go to population health, and being healthy is the best insurance of all, and that's our responsibility.
I wish we had more time to continue this conversation. I have really enjoyed this, a very rich conversation. Thank you so much for being here today. A great discussion. Let's thank them.
Thank you for moderating.